welcome everyone to our information and support session. The philosopher Simone de Beauvoir wrote, "To lose one's confidence in one's body is to lose confidence in oneself." My name is Kathleen Helgeson, and I'm the coordinator of the Patient and Family Resource Center. And I'm joined today by Dr. Ann Katz, author and sexuality counselor at Cancer Care Manitoba, who will be sharing her knowledge and leading our discussion about body image and coping with change. We are very pleased to offer this session with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusion and reconciliation and encourage others to do the same. Before we continue, there are a few basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question for Dr. Katz at any time during the session, just click on the Q&A icon on your screen and type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. My coworker Ellie is also here off screen and will be helping manage your questions as they come in. If you have a technical concern, you can ask Ellie in the Q&A and she'll answer your question privately and try to assist you. I think that we're going to leave the closed captioning off. I just was going to make a note about the closed captioning, but if anybody is having any audio problems at all, just let us know in the Q&A and we can always turn on the closed captioning, but some people find it a little bit distracting, so we've opted to turn it off today. So let me introduce Dr. Ann Katz. She is the author of over a dozen books and numerous professional articles, and she's also the host of her own podcast. Ann is an international traveler, teacher, and speaker, and we are so privileged that she has been based here at Cancer Care for over 20 years as our very own sexuality counselor. Welcome, Ann.
Thank you so much, Kathleen. Always happy to be here.
I just wanted to point out before we begin that we've had a great response from both men and women to this webinar today, but I think it's safe to say that this is still a topic that a lot of people feel quite uncomfortable talking about, and we were pleasantly surprised by the number of people that have registered.
Yeah, it's that's certainly very interesting for me, and you know, just a little plug for my services. If all 56 of you want to, well, not you can't show up in my office because of COVID, but if you know, if all or some or half of the 56 people here want to seek my professional advice and support at any point, I'm open and available for appointments. So just speak to your oncology care provider and they will refer.
And is it an obstacle that you often find in your work that people are reluctant to reach out and ask for help around this topic?
Absolutely. You know, this is a sensitive topic. And I think there's also a lot of misunderstanding about what this work is. So I've had people say to me, do I have to get undressed and you're going to examine me? Good grief, no, not at all. I'm a nurse, but no, that is not happening. I even once had somebody ask me if they were going to have sex in front of me. It was a very, very definite no. If anyone, any professional ever suggests that, just run. It is absolutely not something that any kind of counselor, sex therapist does ever.
Okay.
So really, it's about talking. And for me, it's actually mostly about getting the person to talk to their partner.
Mm-hmm.
We're going to be really what it's about.
Yeah, and we're going to be talking more about that for sure. And before we go there, I just would like to get some feedback from our audience to get a feel for who's in attendance today. And so what I'm going to do is I'm going to launch a poll to your screen. And this first poll is just asking about what are some of the changes, to your body that you've experienced since your cancer diagnosis. So I'm going to launch that first poll and we'll get some feedback from you, and then Ann, you can comment on the results. So you should be seeing a poll on your screen. If you're not getting the poll, you can write a comment in the Q&A and Allie can relay it to us as well. So we have some results coming in. We'll just give it a a minute or so to get as much as we can. And you can check any of these that apply. Okay, I think I'm going to end the poll right there. Or, whoops, we've got some more coming in. Let's let it keep going.
It's a long list, Kathleen.
It was a long list. I guess there's a lot of things that can happen. Okay. So we have about 86% of our people that have contributed. So I'm going to end that poll and share the results with you. So Anne, are you seeing the results there?
Yes. So, you know, what I'm seeing here really is what I see in my practice all the time. Fatigue, lack of energy, you know, that plays a role in so many of the things that we oncology care providers suggest to people to help with energy. And I know it sounds absolutely silly, but physical activity actually really helps to mitigate fatigue and or loss of energy. And, you know, I think we've all heard the term too tired for sex, and I'm using the term sex really loosely here. I'm not just talking about sexual intercourse. I'm talking about the vast array of things that people do, hopefully in a loving relationship, but sometimes it's a hookup. Certainly pain is a big issue for you know, most people, I would suggest. I think it's a very small percentage of the population that enjoys pain with sexual touch, but they exist. Weight changes and hair loss, skin changes, including scars, certainly all play into the topic today of body image. And yes, you know, changes in sexual desire, which is impacted by fatigue, pain and discomfort, weight change, hair loss, etc., etc. So yeah, these are, you know, really very common things that individuals with cancer, treated for cancer, extending way into the survivorship phase of this disease experience. So thank you, everybody, for your honesty and your willingness to participate in this poll.
Yeah, thank you. When we look at those changes that you know, that can occur through cancer treatment, what effect does that have on body image? Like, what do you notice that how do they start looking at themselves?
So I want to preface my answer with a common misunderstanding that body image is something that really bothers women and not men, and that is not true at all. You know, certainly we are bombarded with ideal bodies all the time on television, newspaper, ads, etc., etc. And unfortunately, we really are seeing a real impact of these messages on men who are expected, you know, to have those broad shoulders and muscular arms and a 6-pack, a 12-pack, a 24-pack. I'm not sure how many could go in much further than that. So men certainly are aware of their body and all of those messages. And, you know, to a certain extent, I think I fell into that misunderstanding in the beginning of my practice. And what I have now heard, particularly for men with prostate cancer who are on the testosterone blocking medications or androgen deprivation therapy, and they tend to lose upper body muscle strength and gain weight in that spare tire, that abdominal area. Some men will also develop excess breast tissue, and that impacts on body image really significantly. And men have explained it to me in really interesting ways. One man said to me that he always used to wear like golf shirts, and now he's embarrassed because they tend to cling to the body. So he had to buy a whole new wardrobe, right? He was now wearing cotton shirts, you know, that probably required someone to iron them. So you know, certainly that affects men. Scars, absolutely. And, you know, even if the scar is in a place that is really not public, it is still becomes a reminder of the cancer and its treatment, you know, a reminder of difficult, painful times, and certainly for women. The other thing that I also hear from men on this androgen deprivation therapy is they're really concerned about losing the hair on their head. So male baldness, you know, even though many men have normal male pattern balding, it can be an issue for some men. And then, of course, for women, you know, a myriad issues related to a missing breast, a misshapen breast, a breast that looks different, resulting in difficulties finding a good bra or particularly a swimsuit, big issue, and hair loss. So, you know, if people can see me, I'm obviously not, you know, one of those women with flowing locks, never have been. I enjoy my unnatural blonde, very short hair. But for women, for many women, long hair, you know, even if it's hair to hair, is really an outward sign of their femininity and part of what they feel it makes them attractive. Loss of eyebrows and eyelashes during and after chemotherapy, and loss of pubic hair. We have to talk about loss of pubic hair as well. So I hear from women that when they have lost pubic hair, and I know that many women choose to spend lots of money getting hot wax put on them to rip out their pubic hair, and that's your choice. But I hear from women that when they lose their pubic hair, it makes them feel like a little girl. And there's this discordance between being a sexual adult and being, you know, being a little girl. And for some women, it just feels really, really strange. Yeah. So, you know, certainly weight loss, weight gain for both men and women. For some people, when they have more advanced cancer and they've lost a lot of weight and they're very, very thin, it's extremely distressing because it's a real visible sign to everybody, strangers, right, that you're sick, that you have cancer. And certainly weight gain, stretch marks from being on steroids, which is, you know, quite common with chemotherapy. We give people steroids to help them. And there's this, you know, really sudden weight gain resulting in stretch marks. And stretch marks don't go away. They're there forever. So once again, a constant reminder.
Yeah. So when we talk about body image, is it the same as saying self-image, or does your body image have an impact on your self-image? How do you distinguish that?
Absolutely. I think body image is a part of how we see ourselves, both as men and women, or somewhat androgynous. That all forms part of our self-identity as well. Right? Part of my identity is I'm short. I'm 5'1", or I used to be. I might be 5 foot and a bit now, thanks to menopause. You know, this is who I am. I have very, very short blonde hair. That is very much a part of my identity.
Your identity, yeah. So part of this, the change can involve a loss, I would say, like a loss of identity, and then that feeling of grief and sadness, I imagine, that goes with losing a sense of who you are as a person.
Absolutely. And unfortunately, it's actually one of the most difficult things that I as a counselor have to deal with. You know, I hear a lot, and you know, every now and then I've had a slip as well, when somebody has had cancer, and well-meaning friends and strangers will often say, but you look fantastic. And it doesn't matter what they think about how you look, it's how you think about how you look. And, you know, those people are not trying to be mean. They really are well-meaning and they want to make you feel better. But being told that you look fabulous when you don't feel fabulous, and it happens over and over and over again, and it can really be wounding. So, yeah, you know, physical changes really do impact on how we see ourselves and how others see us as well. You know, and I think a lot about people who've had head or neck cancer, so the oral cancers, right, where our face is what we used to present to the world. Now we present our eyes and forehead. But our face expresses emotion, and really is what other people see. So people with head or neck cancer really do suffer incredibly, because you can't really, well, now you can, but you can't really hide that under normal pre-COVID circumstances.
Yeah. So is it fairly common that a lot of people going through cancer treatment will feel less attractive, less spontaneous, feel less sexual, like when they're going through this?
Yeah, extremely common. I've had back in the day when I would see couples in my office, I not uncommonly would hear a woman say to her partner, this is the trick where they start talking to each other, and I just sit there. No, not really. I'm actively listening. But I've seen and heard women say to their partner, "How could you possibly want me? I am so damaged." And the partner generally is like a deer in the headlights, because, the truth of it is that most of us don't see our partner as how they were 10, 20, 30, 40, 50 years ago, right? We don't notice those changes that happen with aging and gradually. And in it, we really do love the essence of our partner. So, here's this poor partner thinking, how do I answer this without putting my big foot in my mouth? And at that point, this is where I would intervene and say, hey, right, what do you see in your partner? Do you love them any less because they are wrinkly, maybe 20 pounds heavier than they were in their 20s? And of course, the answer is no, right? My partner has been an amazing parent and an amazing partner and has supported me, and, all that kind of affirming stuff. But certainly it makes people just feel bad about themselves.
Yeah. And do you find when you work with partners that sometimes partners suppress how they feel because they feel that they're being selfish to even want to feel differently? Like if they're the partner of the person that has cancer, do they sometimes suppress their own feelings or their wants or needs because they feel that it's selfish to have any wants or needs?
Absolutely. So, and I think both parties do that, right? We try and protect the other person's feelings. That's part of love. That's part of intimacy. I mean, that's the real meaning of intimacy is emotional connection. And vulnerability, and being able to be open about your thoughts, feelings, fears, etc. So yeah, there's lots of protecting the other person's feelings, so people don't tell, the honest truth. So one of the things that I've actually seen for women who've had chemotherapy, whether it's for breast cancer, hematologic cancer, gynecologic cancer, colorectal cancer, is that the chemotherapy will often push them into menopause. So we call that, premature menopause or chemically induced menopause. Women who've had surgery and had their ovaries removed, that's surgical menopause. And these women will often have very significant vulvar and vaginal dryness. And I stress the vulva part because we often don't talk about that. The women's down there is all about the vagina. There's like a whole lot of other stuff going on down there too. So any kind of penetration or sexual touch can be really, really painful. And some women don't come and see me, and they grit their teeth in order to get through whatever it is that they do, because their partner has been so supportive and so amazing, and the woman feels that she owes the partner a sexual relationship, particularly with, genital touch, penetration. So the woman is literally gritting her teeth. Sometimes there are tears rolling down her face because it's so painful. And I've actually seen male partners develop sexual problems of their own. So erectile problems, premature ejaculation, because they know they're hurting their partner and they feel so guilty right? Because this is important and they have their own needs and desires. It turns into a great big mess.
Yeah.
So, to our audience, if any of you are experiencing any of this, you need to come and see me.
Yeah, and definitely this is a good opportunity to ask some questions from, of Dr. Katz while we have her here in this webinar. What are some of the other feelings that are expressed in sessions that you have with people, either partners or the single people that I imagine that you work with as well? What are some other feelings that come up for people?
So let me talk a little bit about for single people. And this doesn't matter what age they are. There are fears that they will never find a partner because they are damaged. There are concerns about, how do I tell someone that I've had cancer? When do I tell someone? So all the issues around disclosure of a cancer history. How do I tell someone that I cannot father children or I cannot get pregnant? Those are really important questions. And there are no simple answers to all of this, right? It's sort of, it all depends. Well, maybe. There's frustration. Why did this happen? Sometimes anger. This is not fair. We can't all be, I won't ask why, I'll ask why not. And I think it's really people who can do that, I think, are perhaps fortunate or some kind of special person. But it's why did this happen to me? It's not fair. I've been a good person. I've never been overweight. I've exercised every day. I'm vegan, or vegetarian or whatever it is. I've never smoked. I never drink alcohol. Why did this happen? And this really isn't punishment from a higher power. This is a matter of biology, pure and simple. I mean, there certainly are some risk factors, but, biology plays a huge part. So frustration, guilt, anger, terror, fear, sadness, depression. I mean, you pretty much every anxiety in the book, can come out in these kinds of sessions and certainly go on in people's heads.
And you talked a little bit about just going back to your working with couples and about the communication aspect. You've mentioned, I think I had read in one of your books, something about communication versus assumptions. Could you say a little bit more about that?
Oh, I'd love to say something about that. It's one of my favorite topics. So many of us, and I'll include myself here, we make assumptions about what our partner is thinking and feeling because we've known them for 40 years or 10 years or 5 years. And so we think we know what they are thinking or feeling, and we get it wrong. I would suggest probably 80 to 90% of the time. Communication lies at the root of relationships. Communication is so important. And if you make assumptions, you're going to act in a certain way, which may make your partner defensive, confused, guilty, worried, all of the above. You've got to talk. And I think this is one of the most valuable things of counseling, is that there's this magical, amazing thing that happens, that when a couple, or a person for that matter, but obviously the dynamics with a couple are different. When a couple is face-to-face via Zoom, maybe please one day in person again without masks, when you're in the room with a professional, this somehow creates a situation where the two people start talking to each other in a very meaningful way. I and the other psychosocial clinicians who do this work are there to help, to ask probing questions, perhaps, to kind of keep a little bit of control of the emotions, right? If people start to get angry, I'm going to suggest that we take a break, right? Maybe one person needs to leave the room and go walk up and down the hallway outside. I'm not going to let people start yelling at each other. And of course, I would never yell at anybody either. I use tone instead. My kids always accuse me of yelling, and no, I'm not yelling, I'm just using tone. So, communication is so important. Human beings have the gift of speech, and we don't often use it, particularly when it's something difficult, sensitive, emotional. But perhaps it's at those times that we really do most need to use our words.
Yeah, and just kind of relating to this topic about communication, there was a question from one of our attendees about how do I talk to my kids about the changes to my body in terms of like hair loss or changes to the shape of your breasts. How would you encourage people to have that conversation with children?
Yeah, I think it also depends on what the relationship or the values, right, in the family anyway. There's some families where people walk around naked all the time. There are other families where things are very closed door. I think it's really important to talk to children, and particularly to provide them with some anticipatory guidance. Mommy's hair is gonna fall out, but Dad's going to shave my head before that happens, because to suddenly appear, with big clumps of your hair falling out is really scary for children. I like to approach conversations with children, from the perspective of sort of an opening statement that's not really very graphic, and then see what their question is. Children will ask to the level of their understanding. So I think sometimes we have to be really careful about giving them too much information, because it can be really, really frightening for them. But children are also really accepting for the most part, right? What's important to kids is the presence of the parent, the love and the hugs and the reassurance as well. Daddy's going to look different while he's having treatment, but he's still the same person. And I know that we have psychosocial, I know I always trip on that.
Because it's hard to say.
Psychosocial clinicians here at Cancer Care Manitoba who really are so well equipped to talk to people about the best way to do this. And there are books in the resource library about this as well that are really, really helpful. And, is there a perfect way to do this? No, you just do the best you can.
Yeah, and we do have some great resources here, and I can still mail those resources out to people, even though the library right now is closed. We can send things out in the mail if anybody's interested. When we talked to you, you said that it was really a misconception that men are more accepting of changes to their body than we think that women might be. But I'm wondering, like, do men also put on like a brave face when it comes to this, like that they give the impression that they can handle it more so than women? Or is that something that you see, like that they feel that they can't ask for help, or they should just kind of, suck it up and deal with it, and women are more inclined to ask for help and get the support they need?
I think that has really changed over time. Traditionally men, or we believe that men have been socialized into that stiff upper lip, etc. And certainly I've seen more like men who have a public persona, right? Presidents or prime ministers. I mean, I've seen them cry openly, including elderly men who I think, often have come through that socialization about, boys don't cry and things like that. So I think that certainly there are some men who have been socialized to be really, really stoic, and they cope the best that they can. Often there'll be a little chink in that armor, right? And those of us who do this work can often identify that little chink and just zone in. I certainly don't. I don't have any problems with men crying in front of me. It's good for our eyes, and it's a way of expressing those fears, etc. That people go through when they have cancer, and it certainly signals to me that there's something going on there, right, that needs to be attended to.
And what type of advice do you give for people that are really struggling with the type of changes that people have indicated they've had, like in terms of coping with these changes that are occurring, what advice do you give in sort of is there sort of general advice that you can offer?
There's never general advice, right? It's very specific. But I think one of the things that can be really helpful is to talk about what can your body do, right? Not what does your body look like, but hey, you managed to get yourself here to 675 McDermott Avenue, and you managed to, get up to the 3rd floor and come to my office, right? Your body brought you here. And there was probably a time when you were really sick and couldn't do that. How are you managing at home? Are you doing any of the usual things that you used to do? And that shows that your body, right, is able to do stuff. And I think sometimes we pay a lot of attention to the outward stuff, and that really is something that that changes really quickly and easily. I certainly don't look like I did in my 20s. Are there times that I'd like to? I'm not so sure anymore. There's a whole lot that I can do, and I'm happy for that. So, it really is on an individual basis and individual circumstances, which are so important.
I like that you also mentioned just about aging in general, because I think that is a struggle that we all have too as we age and our body changes, not even due to cancer, but just the impact of aging on our body. And as you said, sometimes it's that clinging to what was as opposed to accepting what is now, that we still want what we had back then, but that may not be realistic. And
our society is incredibly ageist.
Yes.
Right. Do you remember the 40 birthdays was over the hill? What on earth? Right. And 55 plus as the time of retirement. I mean, personally, I don't know anyone who retired at 55 anymore, because we are able, right? And we are engaged in the work that we do, and work brings us meaning and purpose. So, I don't know, does it have to be 75 plus now? Should that be the new tagline? But yeah, some women who perhaps are sort of in their 40s and 50s or beyond can perhaps relate to this. But I remember once walking with our daughter in Polo Park. Haven't been there for about 3 years. But I was walking with her in Polo Park, and there was some young men walking towards us. And it suddenly occurred to me that, and this is going to sound weird, and I don't mean it to be weird, but I was completely invisible to them. Right? And it suddenly hit me, right? I am no longer a young woman. I mean, certainly there were other signs as well. But there's a certain invisibility, I think, that comes with age. And I think for men, it is perhaps a sense of not being that useful or able anymore. And listen, if you're lucky enough, we're all going to age.
Right. That's true. Yes. I try to remind myself that as well, right? That it's a privilege to have to cope with aging. Let's talk about some of the unique struggles that women face during cancer treatment, and what you've seen in your work with women in terms of some of the issues around body image. What do you see as being some of the bigger obstacles and barriers that people face, that women face?
I think, and I think we've touched on this, if not dealt with it in some depth. But that pressure that we put on ourselves to look a certain way, I think is really big. The other thing is the whole issue of breast reconstruction. So women with breast cancer who have a mastectomy, while the research suggests that women who've had a mastectomy have better body image than women who don't, and I hear a lot of this, the reconstructed breast or breasts, because some women opt for bilateral mastectomy because they think they'll have a better aesthetic outcome, etc. But one of the things that I think we don't talk about enough in that chaotic time of treatment decision-making, right, where women are asked, what do you want? What is left out is the role of breast sensuality. So breast sensuality refers to the role that the breasts play in a woman's sexual response. So a woman who's had a mastectomy with reconstruction, even though in clothes she may look great, the reconstructed breast or breasts often do not look like her breasts pre-cancer and pre-surgery, and they certainly do not react or respond in the same way. And I've had numerous women say to me, if I was warned, or if I acknowledged or recognized that my breasts, my nipples, whatever, were an important part of my sexual response, I may not have opted for a bilateral mastectomy because now I have lost sensation in my breasts. My breasts feel numb. They don't look like my breasts used to, and they are no longer responsive to touch. And so my sexual response, my arousal response has been impacted negatively. I mean, really negatively. It's lost, it's gone. There's a wonderful breast surgeon in the United States by the name of Dr. Jennifer Goss, and she has done research and written extensively about breast sensuality and how we need to be talking to women about the potential for loss of the sensation, arousal, etc. So you know, lots going on there. And a lot of mourning and grief.
I imagine. We do have a question from somebody that is saying that they've had a lack of confidence since having their breast reconstruction and feeling very self-conscious. Is that something that you've found working with women?
Yeah, you know, so the feelings, right, the emotions may persist for a long time, even if you know, the body is healed, because those are two separate things, and that loss of confidence is really important.
Yeah. You have talked a little bit about vaginal dryness as well, and the pain associated with that. Is there anything that you suggest for women? There's a question from one of our attendees about what would you recommend or suggest for that if sex is painful, intercourse?
I suggest they see me, and I have a whole range of options for them in terms of vaginal moisturizers. Certainly good lubricants, not KY jelly. That is your grandmother's lubricant. Throw it out. And I'm sometimes amazed, you know, I'll see women and their gynecologist told them to use KY jelly. Wrong. You know, if anybody wants to go on a little mission, go to your local pharmacy, and where the condoms are, right next to it, are where all the vaginal moisturizers and lubricants are. There are dozens of them. It's really confusing. I have handouts with images of products that I recommend because I've looked into them and know what the products are. Lubricants and moisturizers, I could write a thesis on it. It's about osmolality and pH and all kinds of scientific things. But certainly, you know, I mean, I think everybody should be using a lubricant for penetrative sex and sexual touch, actually, for that matter. So this is an extremely, extremely common complaint. And probably of the women that I see as patients, I would say a good 80 to 90%, that is what we would call their presenting complaint or presenting problem.
Someone else has just written too that they feel afraid of having sexual intimacy with their husband because of thinking about the cancer that's within. Like, is that something that you notice for people that are coping with cancer, that they feel that maybe it could exacerbate things, or that there's some fear around that?
So Ali, I just saw a question about how can people get a referral to me. You can certainly ask your oncology care provider, your oncologist, your nurse. If you're seeing one of our psychosocial clinicians, they can refer to me, but you can also just give me a call and I will arrange an appointment. So you can self-refer.
Okay.
So Ali, if you would just pass on my direct line to people, 204-787-4495. That is my direct line. I'm here from 6 till 2 every day. The best time to reach me is between 6 and 9 in the morning because I'm a morning person. Kathleen looks horrified. I might as well be here because at home I'm just going to be roaming around. So I'm at my desk. I'm doing my sort of thinking and writing work, and I answer my telephone. So, otherwise, if I'm seeing patients, I don't answer the phone, and then I'm playing telephone tag with people.
Yeah, that's great. And I love that you're so accessible and to people that want to, seek some help from you, that you're able to just answer those calls directly. It makes things a lot easier than waiting for a referral.
Yeah. I also just saw a suggestion about vitamin E oil. Vitamin E, first of all, you should not put any oil into the vagina. So if you want to use vitamin E on the outside, on the vulva, go ahead. Pharmaceutical grade, I don't have any concerns about that, but not into the vagina. The vagina is first of all, it's a self-cleaning organ. So you shouldn't be putting any douches or whatever. You're not supposed to smell like spring rain. And any oil in the vagina is going to alter the delicate balance, the pH, the good bugs that are in the vagina, and keep the bad bugs or germs. They're not actual like creepy crawly bugs, sorry. But they are good germs inside the vagina that keep everything in balance. And oil or lubricants that contain glycerin or polypropylene glycol, which is used as a preservative, can really alter that delicate balance. So no oils in the vagina. I don't care if it's coconut oil or peanut oil or olive oil or any of the myriad oils there. Vaseline, hand lotion, you'd be surprised what people will use, should not go in the vagina. Leave it alone.
Just one question again relating to that, and then I'd like to come back to that other question because I don't think we got a chance to hear from you on that. But relating to dryness, does that eventually go away, and does libido come back naturally?
So the dryness does not go away unless you are using some local estrogen, often in the form of a little tablet that is inserted into the vagina. And there's also a cream, which I'm actually not a huge fan of because it's difficult to get an accurate dose, and it's kind of goopy. It'll leak out and land up in your underwear and all kinds of stuff. So local estrogen is the only thing that will actually get to the root cause of the problem, which is lack of estrogen. And I just forgotten the beginning of the question.
Yeah, and will over time
it will not get better by itself.
Yeah, okay.
No. So there's a natural loss of estrogen through the natural menopausal transition, but surgical or chemical menopause is sudden and abrupt, and you don't get used to it, right? Sort of over time. And very, very distressing, very, very painful. And pain impacts on desire or libido, right? Most of us don't want to do something that is going to hurt like the dickens. And one of the issues for women is that if there is pain with sexual touch or penetration, the muscles of the pelvic floor are going to do what they were designed in part to do, and that is they are going to really become very contracted. They're going to shut the entrance to the vagina, and then you'll end up with a whole host of pelvic floor problems that can impact with urination, with bowel movements, certainly really, really painful. So, you know, the body protects itself, right? So pain with sexual touch or penetration leads to pelvic floor dysfunction, you know, and that's another whole issue that has to be dealt with.
Going back to that previous question, there was a comment from one of our attendees saying that they were afraid of having sexual intimacy, thinking about the cancer within.
Yeah. So yeah, you know, first, you know, what I hear a lot of is, can I pass cancer to my partner by having sexual intercourse? If I'm having radiation, is this somehow going to, you know, affect my partner negatively? If I'm having chemotherapy, you know, is this an issue? And actually, that's the one area where we do advise people who are on chemotherapy to use a barrier method for sexual intercourse, because there is a risk. And this is a very kind of blurry topic, but there is a risk that the breakdown products of chemotherapy may negatively affect your partner's skin, for example, or tissues. So we generally advise that you need to use a barrier method, a condom or a dental dam, and that they are different purposes. So let's just keep it to the condom if you're having sex with a man. So if he's having chemotherapy, he needs to use a condom. If you're a woman and you're having chemotherapy, your male partner needs to use a condom for sexual intercourse, for penetrative intercourse, for 36 to 72 hours after chemotherapy. I know someone's going to ask me about oral chemotherapy, and the answer is we don't know. We honestly don't know. And it's a problem, right? Because oral chemotherapy is sometimes an everyday thing forever, right? It's not like IV chemotherapy where you have, 3 treatments or 5 treatments and then a break of a couple of weeks. So this is just something we haven't figured out yet.
Mm-hmm. Yeah, so there's anxiety just around the act itself, and and it's hard to, again, as you say, that interferes with the pleasure, the spontaneity, if there's anxiety and fear.
And the brain is the biggest sex organ, right? So if you are afraid that your partner is going to be hurt by something going on in your body, or you are going to be hurt, or that penetration is going to cause damage, it causes anxiety. Mm-hmm. Absolutely. But, there are many different ways of being sexual. And people can experience pleasure in different ways without penetration. So, honestly, I got a whole whack of ideas for you.
Good. There was a comment about one of our patients said that they have been told not to use estrogen because their breast cancer was estrogen related.
So this is a great question. And in fact, I just had an interesting email correspondence with one of our radiation oncologists about just this. And there has been a fair amount of research in recent years about the risk of local estrogen for women with hormone-dependent cancer. The risk is very low. There is very, very little systemic absorption, which is really what we're worried about. The effect of the estrogen tablet that you put in the vagina, it's called Vagifem. It's 10 micrograms. It's a very low dose. There, it acts on the tissues of the vagina. And there are probably as many oncologists who won't hear of this for their patients as there are oncologists who think that if a woman is informed about the very small risk, women will make the right decision for themselves. I'm not a medical oncologist or a radiation oncologist, but I truly believe that a woman who is educated, who understands the infinitesimal risk, will make a decision that is right for her. It is a balance of the impact on your relationship, the impact on you physically and emotionally, and that women will make a decision that is right for them. I believe that with every cell in my body. So this particular radiation oncologist, who was, his email said, what do I do? I don't think local estrogen is safe. And my response was, I am going to show you the latest evidence. And I did a literature search today, and I've come up with 6 or 7 articles, recent articles that I want him to read. And I said, I will provide you with the latest evidence about this. And I really hope it helps you change your opinion and really listen to and respect the decisions of women. I'm not suggesting that he doesn't. I'm really not suggesting that. But I think, we want the best for our patients. We really do. And we don't want to see somebody get a recurrence and then we feel guilty, because we do. So that's a very long answer to a very, very excellent question.
I'm going to switch gears right now just to talk a little bit about some of the unique challenges for men, but that doesn't mean that we can't come back to more questions from women. We actually we'll probably have significant time, but just looking at some of the issues relating to men, I do have a couple of questions right off the bat that were asked. So one of them was, how long will it take before I can have an erection following a prostatectomy?
So a radical prostatectomy is removal of the prostate gland, the seminal vesicles. Upwards of 80% of men are unable to have erections after the surgery. There are a whole lot of reasons for this, including damage to the nerves that control erections that run on the outside of the prostate gland. Depending on what your erectile function was like before the surgery, depending on your age, those are the 2 factors that, the research tells us are most relevant in terms of the return of erections. However, once again, the brain is the biggest sex organ, and men psych themselves out. They so much want to see the return of spontaneous erections, which doesn't happen for upwards of 80 and 90% of men. They are so focused on this happening that it doesn't. It's called performance anxiety. Even with pills like Viagra and Cialis, etc., they work about 40% of the time, and I think that's perhaps an overly optimistic view of this. After that surgery, it's big surgery, and this is a huge loss for men who are used to spontaneous erections, sometimes even when they don't want to have them. I'll never forget a lovely elderly European gentleman that I saw for counseling. And he said to me, doctor, I always used to be late for everything. And I'm thinking, what? What does this have to do with anything? And I said to him, could you explain more? And he said, well, when I was a young man, when I was a young man and I'd be sitting or waiting at the bus stop for the bus to arrive to take me to work or to the movies or whatever, and a young woman would go by. Well, you know what would happen? I said, He said, and then I couldn't get on the bus. So then I would have to wait for the next bus. So I was always late for everything. So I just thought that was just such a charming way of explaining the challenge of male aging, right?
Yeah.
So, and I see there's a question here that is connected. So for someone who's had their prostate removed, then had radiation, yet another insult, right, to the poor penis, and now is taking hormone therapy or androgen deprivation therapy. I prefer the term androgen deprivation therapy because it's saying it like it is. This medication, which is sometimes called hormone therapy. To me, hormone therapy sounds like we're giving you hormones. And with androgen deprivation therapy, we are doing the exact opposite. We are stopping the man's production of testosterone. So, after surgery, radiation, and androgen deprivation therapy, which really men can sometimes have for 24 months, 2 years, the chances of spontaneous erections coming back, or the ability to have erections even with something like Viagra, is very, very low, unfortunately. And Mr. Anonymous attendee, I'm really sorry about this. And often men who are on androgen deprivation therapy, Viagra doesn't really help because testosterone is actually involved in the pathway to have erections. However, there is a solution. And all the men listening, you're going to cross your legs when I say this. Penile Self-Injection. So, you know, I don't think this is anyone's dream. Kathleen is looking slightly surprised, shocked by this, but this is a method whereby I teach the man how to inject a small amount of medication into the side of the penis. Yeah, it's a needle in the penis. I get it. But it works. And it can even work for men on androgen deprivation therapy. Sometimes it's, you know, it's really a little bit difficult. It's a local response, which promotes opening up of the blood vessels so that blood flows into the penis. Erections are incredibly it's a really complex phenomenon involving nerves and blood vessels and cellular activity and all kinds of stuff. So, you know, certainly, Mr. Anonymous, if you want to talk to me about it, see what your options are, just give me a call. Ali, I think, has put my phone number up, and I can certainly give you information that hopefully might be of benefit.
I did really enjoy your conversation you had on your podcast with Dr. Barry McCarthy, and he talked about, I think it was anti-perfectionism, and in terms of relating this to men's, I guess, the pressure they put on themselves to have this perfect performance, and that every sexual experience is going to be perfect. Could you say more about that conversation that you had with him?
Yeah, so Dr. McCarthy is a retired psychologist. He's written a number of books, often with his wife. They co-author these books, and his focus is on the good enough model, right? That you know, despite what we see in the movies and on television about, you know, sex being this mind-blowing, life-altering experience each and every time, sometimes it has to be good enough. So he really does put a focus on communication, pleasure, as well as eroticism. And, you know, I think that's his work is so interesting. And if you Google his name, you'll see all the books that he has read. I have most of them on my bookshelf here. I've got so many books, so much money has been spent in buying books. I love books. So, you know, over time, there's real interest in sex for older people. So people over 50, over 60, over 80, over 90. And really, you know, his name is Dr. Barry McCarthy, Jocelyn. MCCARTHY. And his books are easy to read and just contain so much great information. And, you know, I think most of us have learned about sex from books, you know, his throbbing organ, and her, you know, complete submission, good grief, and movies and television. I grew up without television. I'm from South Africa. Television came to South Africa when I was actually 18, finishing high school, and it was terrible, but that's besides the point. And when we moved to Canada, and I started watching soap operas because I was at home with a baby, and I just couldn't believe what I was seeing. You know, first of all, these women were having sex. Their hair was absolutely perfect. No smudge makeup, just a little bit of a glow. And then they got up, got dressed, and went to work. They didn't even go to the bathroom, right? And that honestly is, I think, how most of us have learned about sex. And it is completely unrealistic. People knock their elbows, they fall off the bed, they bump their head. It's
Yeah.
noisy. People fart. So, they're not going to show that on television. So, yeah, I think that perfectionism actually is not just for men, it's also for women.
For sure. It makes me think there's this movie, Lady Bird. It's sort of a coming of age movie, but the main character loses her virginity to her boyfriend, and she says something after, something like, I was just hoping that it was going to be special. And his response is, why? He goes, you're going to have lots of unspecial sex in your life.
And Kathleen, this is not a criticism, but when you said loses her virginity,
Mhm.
there's a wonderful, wonderful sex therapist by the name of Dr. Laurie Mintz, also somebody who I interviewed on my podcast. And just today, she tweeted something about this concept of losing one's virginity.
Mhm.
And virginity somehow is a gift that you give to someone special. And what a fuss is made about this. And she says we've got to do away with that kind of thinking,
Yeah.
because just the term losing is such a negative term, right? I lost my phone. That's a real problem
Yeah.
for me, right? It's not losing anything, right? And it's really not pleasure focused. And I think when we start teaching particularly young women about their right to sexual pleasure, right? And the need to communicate what feels good to a partner, because how on earth, right, are they going to know what feels good to somebody else? Anyway, we're sort of off topic, but
Yeah, but I think it's very true that, as you said, I think the misconceptions start very early, in our years, and then just continue because of lack of communication, and people feel, as you say, this pressure to have certain performance that is unrealistic.
Unrealistic, yeah.
Can you talk a little bit about discordant desire? That's a term that you also have used.
Yeah, so, generally, and certainly desire or libido goes up and down daily, weekly, monthly, depending on what's happening in your life. For some women, in the mid part of their menstrual cycle, they have high levels of desire. It's hormonal, and it's actually the time you're most likely to get pregnant. So thank you very much for that. Men also, their desire waxes and wanes. Men who are stressed, right? Some men will actually really be more interested in sex because for 10 or 15 minutes, they can forget what's going on. But for other men, when they're stressed, they lose all desire. Same thing for women. Women sometimes who are pregnant at certain times in their pregnancy are highly desirous, and then at other times aren't. And often in relationships, in couples, one individual, it may be the man, it may be the woman, or if it's a same-sex couple, it might be one of them, has higher sexual desire than the other. And if you don't talk about it, you get avoidance, and you get frustration, and you get anger and conflict, right? And things don't go so well. So there are a number of books that I think are very, very helpful. So one of them is called The Sex-Starved Marriage, and that really does talk about discordant desire, right? The other thing is that women often think that we have to be desirous in order to be sexual, right? And that speaks to something called spontaneous desire. And I'm going to explain the difference between spontaneous desire and reactive desire or responsive desire, which is actually much more common for women and might be for men under certain circumstances. So the best way I have of explaining this, spontaneous desire is when you're walking along or you're in the grocery store, and a man or a woman, depending on who you desire normally, an attractive person comes walking toward you, and your first thought is, I'd like some of that. Now, some of us never have those thoughts, and that's okay, right? That is spontaneous desire. In the context of a relationship, it might be, I cannot wait for my partner to come home from hockey because I'm really in the mood. Spontaneous desire. Responsible reactive desire is when you're sitting on the couch with your partner, watching television, and you're suddenly aware of their thigh pressed against yours. And the thought pops in your head, that might be a good idea. That is responsive desire. And we know from a whole lot of research that most women, not all, have responsive desire. It's only when something happens, touch, a word or a sentence, partner taking the garbage out without being asked, right? Or emptying the dishwasher. I mean, everyone has their own thing. That responsive desire occurs. It's not there all the time.
Can you talk a little bit more, Anne, about Dr. Katz, about the importance of touch and whether it's sexual or non-sexual and just how it impacts us?
Human beings need touch in order to survive. Without touch, we get skin hunger, right? I remember in our first lockdown here in Manitoba, and I could not see my grandsons for 3 or 4 weeks. I have a loving partner who I adore. We've been together for 40 some years. Yes, I was a child when I met him. And we hug and hold hands and do all that kind of stuff. But I had skin hunger for those 2 little boys, right? Who hold me and hug me, right? And have physical contact with me in a very different way than I have with my partner. So human beings have a fundamental need for touch. Those of you who are old enough may remember those Romanian orphanages. Do you remember that heartbreaking footage of those little kids in those cribs banging their heads against the wall, self-stimulation, because nobody touched them. So yeah, touch is important. And touch often goes away at times of stress. And certainly, I think, after cancer, where for some people, chemotherapy has caused peripheral neuropathy. So touch actually hurts. Skin sensitivity, rashes, itching, those kinds of side effects of medication. And also, touch goes away when you are being sexually avoidant, right? Because you don't want to get anything started. And then you and your partner land up, right, with that skin hunger. So sometimes you actually have to say, I need a hug, but it doesn't mean I want anything else. I just want a hug. This goes back to the importance of communication, because your partner, if you don't say that, your partner may interpret that hug as initiation for something else, and then he or she will be hurt, disappointed, frustrated, because all you wanted was a hug.
What would you advise people if they felt that they wanted to have this discussion with their partners or talk more broadly about body image and sexuality, and they felt that they had a difficult time bringing this up with their partner? How would you suggest that they kind of talk about this subject or bring this subject up?
Come and see me, and I will make you talk. No, I'm kidding. But I can certainly facilitate that conversation. I don't have truth serum. You can still keep secrets, but by asking questions, I can. And, and certainly with relationship issues, not necessarily sexual issues. And I work closely with our psychosocial clinicians who will always refer to me because we're really clear sort of on the boundaries of our work. There's certainly some overlap, but I think we're really clear, about what I do and what they do. And, just get some help. It's free. That is huge. you know, in the days when I used to travel around giving talks at cancer centers and hospitals, somebody would always stand up and say, how do we get one of you? Well, you know, I'm not sure I should be cloned. There's some sides of me that, you know, perhaps shouldn't be reproduced again. But, you know, this is unique that you have somebody here with the education, training, and certification. So I'm a certified sexuality counselor with a specialty in oncology. And as a doctorally prepared nurse, I understand the effects of medication, the effects, you know, the pathology, the physiology, the endocrinology. I mean, all those things that come into play that impact on your sexuality, whether you're single or partnered, and it's free.
It's a great service. There are some more questions that I still would like to ask you, and we still have time for our audience to ask questions as well. I am going to just launch the second poll that we had, and I don't want to do that. So let's just seeing if I can get the second poll. The second poll was to ask about what obstacles. There we go. Yeah, what obstacles you face or what you feel exist for you in terms of seeking help. So just to get a little bit of feedback. So I think you should be seeing that poll on your screen now. Basically asking what's my biggest barrier in terms of addressing body image or sexual changes after cancer treatment. And again, if you don't see that poll on your screen, you can provide a comment in the Q&A. Just while we're waiting for those results to come in, and I do have another question for you, and then somebody's written, how do you get your head around the fact that you'll be wearing incontinence briefs for the rest of your life?
Yeah. So the first thing that I would do is I would say, you need to address the whole issue of incontinence and what can you do to improve that situation. And there's an answer for that, a pelvic floor physiotherapist. These are physiotherapists with special training in the muscles of the pelvic floor, and they are a huge help for people who are experiencing incontinence, because it's like 98% because of something going on in the pelvic floor. I recommend Nova Physiotherapy because the person who owns that clinic, she's a physiotherapist. She has a PhD in pelvic floor physiotherapy. Who knew that even existed? I'm always concerned about physiotherapists who have just done a weekend course and they really don't get much education in their program, in the physiotherapy program, about pelvic floor. So Nova Physiotherapy, you do need a referral, I believe. So your family doc can refer you. If you see me, I can certainly refer you. Your oncologist or can refer you as well. Yeah, you know, adult diapers are not exactly the sexiest things around. They certainly are better than they used to be even 5 years ago, you know, which speaks to the demand, right? These companies wouldn't be making these things and advertising them on television, even though you don't really see a lot of ads for men. You see a lot of ads for women.
Exactly. Yeah.
So they're missing a big chunk of the population there. You know, they certainly are better. Yeah, but incontinence is, you know, it's really bothersome and it's social, right? I mean, people often, their lives shrink because they're so afraid of having an accident because then people will see. So yeah, pelvic floor physiotherapists can be really, really helpful.
Okay. Thank you. I'm just going to end that poll and share the results. So some of the barriers that people have identified, can you see that? And
yeah,
Dr. Katz, yeah, okay.
Yeah, okay. So yeah, shyness, awkwardness, you know, that's why, you know, you can hear, I'm not shy or awkward about anything. I mean, I can talk about the vagina and the penis at the dinner table, and often do. No, I'm kidding. You know, part of my job is to help you feel comfortable talking about this. I don't care what words you use. You can have a name for your body part. I don't care. So yeah, it's kind of awkward, but you know, there are professionals around who can help hopefully overcome that awkwardness. My oncology provider hasn't asked. Yeah, I know. A huge part of what I do is educate oncology care providers about the importance of asking. We talk about diarrhea, constipation, anal fissures. I mean, you name it, vomiting, right? Pus. I mean, we talk about awful things. And yet, you know, doctors, nurses are really, really often embarrassed to talk about it. They don't want to embarrass you. There's this general feeling that if it's an issue for the patient is going to raise it. Mm-hmm. Patients, and we know this is actually shown in research, patients wait for the oncology care provider to raise the topic, because if it was important, right, mm-hmm, my oncologist or the nurse will ask me. So there is this deafening silence. I'm just glad to be alive. Okay, I mean, I can't fault you, right? But you don't have to make sacrifices, right? Sexuality is part of quality of life. It is part of being human. So, you know, I will never take that joy of being alive from you, but maybe your quality of life could be a little bit better. And, you know, we'd like that. It's a private issue. It's absolutely a private issue. I understand that. And that's why, you know, I will never disclose anything about you. Everything that is said to me is in the cone of silence. I do not make detailed notes in the electronic medical record that we use, because it's nobody else's business in case they see that. So I make really vague comments like, you know, couples seen for relationship issues. That could be anything. And if I do want to make detailed notes, I actually have the ability to make my note private. So nobody else, not your doctor, not the nurse, not anybody else who you are seeing, has access to that note. And I do that very rarely. I would rather say to you, hey, what did we talk about last time? Because that will also tell me what you took away from our conversation. And I can then perhaps correct any misunderstandings, reinforce, you know, some of the stuff that I told you. So
there is a comment from one of our attendees just said that their doctor won't address sexuality or intimacy with them. So that's,
well, then you come see me. You don't need a referral.
Definitely.
You don't even need to tell me the name of your doctor, because I will probably have a little chat.
I did want to ask you about the role of dissociation during treatment and what that means, and how one can sort of regain connection with their body. Can you talk a little bit about that?
Yeah, so, you know, this dissociation, what does that mean? This is something that it's a coping mechanism, that when people are doing things to your body, when you are, for example, having radiation treatment, you know, and you're lying on that table and maybe some part of you is exposed, and there are people in the room, kind, professional people, but they're people. What people, and this happens unconsciously, right? And people have described to me, it's like my head left my body and went into the corner of the room, or hovered somewhere up on the ceiling, and I looked down, I could see my body there, right? But it wasn't like me. That's dissociation. Mm-hmm. It happens to people during sexual assault, because it's the mind's attempt to allow you, or to prevent you from your psyche being fractured. I know those are sort of It's a weird concept to understand, but it's really a coping mechanism to trauma. And treatment for cancer is traumatic. Let's not mince words about it, right? It makes us vulnerable. It causes pain. It's interference with our body and how it functions. So the dissociation also prevents you from experiencing pleasure. And I don't just mean sexual pleasure. I mean a massage, a manicure or pedicure for some women. They just can't stand being touched, right? Because it's triggering and reminds them, and their mind kind of shoots back to those not unpleasant, to those horrible experiences that they had during treatment. So that's the issue with dissociation. And if you dissociate when you are being touched, there is no way that you can experience touch as something pleasurable.
Talking about that, and I'm not sure if this is kind of in the same line as that, but guarding. When you refer to the term guarding, what does that refer to?
Guarding?
Guarding, yes.
Yeah, so, the medical meaning of guarding is when somebody has something going on, like let's say appendicitis or a bowel obstruction, and somebody examines your abdomen, your tummy, and we say, oh, there was guarding. That's because the abdominal muscles are really, really tight, protecting what's going on inside, right? But guarding can also happen in a sort of more psychological or emotional way, that people cut themselves off from emotions, from pleasure, from really feeling anything. So it's a way of numbing, and it's not a good place to be.
How do you rebuild that healthy body image, that comfort with your body, the ability to be in your own skin again and enjoy being in your own skin again? How do you rebuild that after these experiences have happened?
Yeah, it's, as I said in the beginning, it's not easy. I mean, I think the body image alterations is one of the hardest things that I deal with. Loss of erections, loss of orgasms, those are sort of things where there are relatively accessible interventions to help, but this body image is really difficult. For somewhere, first of all, I say to people, you don't have to be naked to be sexual, whatever sexual means, right? If you are distressed about, or worried, or anxious about scars, or what your partner is going to be thinking about your altered breast or your ostomy, right? If you are anxious about that, you cannot relax. And in order to experience pleasure, you have to be relaxed. So, you don't have to be naked. I would suggest something other than like a t-shirt from a Grateful Dead concert in 1962. But, a man's shirt, a cotton shirt for a woman. You can undo some buttons, keep other buttons done up. For men, if you have an ostomy, and for women too, for that matter, you can actually buy these kind of elastic, it's almost like a cummerband, but it's stretchy, which will anchor the bag so that it doesn't move, because if you have an ostomy, it's scary to think that it's going to like explode or fall off or whatever. So that, there are certain things that you can do to enhance or enable you to relax. You can also say to your partner, look, this is a no-go zone. This is what you can touch, and this is what you can't touch. Let me draw you a picture, right? And then that avoids, flinching, pulling away, getting really turned off, angry, tearful, right? Communication.
Yeah. A final question, I guess, because we're getting close to the end, but how do you deal with the psychological issues that arise when you start talking about sexuality? Like, do you ever feel that you need to bring somebody else in, like somebody else that's trained as a psychologist, or is that something that you address as a therapist as well, these issues that come up?
Yeah, I mean, certainly there are issues. There are certain things that I will absolutely refer out. So, for example, I am not an expert in childhood sexual trauma. I can certainly listen. I can certainly empathize. I can certainly validate. But I don't get into that aspect of therapy or counseling if that is what the person wants, right? So, I know of people who deal with these kinds of things. And if I don't know, I'm on the phone to one of my psychosocial clinicians, or mostly I'm emailing, like, where can I refer this person to? This is the issue that they have raised. I don't have what we call intimate partner violence in my wheelhouse, treating that, but I certainly know where to refer for that. So, for me, and I think for any other professional, knowing our boundaries, right, and what we can deal with and what we can't deal with is so important, because we don't want to harm anyone.
One final question, just to slip in there. Somebody asked, is there a chance of a complete return to continence when somebody's had issues of incontinence?
Yeah, absolutely. But it takes work. Mm-hmm. So here at the Manitoba Prostate Center, which is part of my job, we send all men having a radical prostatectomy, having surgery for prostate cancer, to see the physiotherapist at Nova before the surgery, and they learn how to do the pelvic floor exercises properly, because you can have a tight pelvic floor to begin with, and you do those exercises, you're going to make it worse, right? So they teach the man how to do those exercises properly. And then after the surgery, they start doing those exercises again. Sometimes I will see a man 6 months, a year, 2 years, 5 years after surgery, and they come and they say, I'm leaking again. I have incontinence again. Why did this happen? My first question is, did you stop doing your exercises? And 99% of the time they say, yeah, I was good. I got this. Got to go back. Got to start again. And I always advise them actually to go back to the pelvic floor physiotherapist for a little assessment. It's invasive. Got to lay that on the table. It isn't for. It doesn't have to be forever, but it's work.
Yeah, well, that is good news. That is good news. And I think that we're pretty much out of time. There's so many other questions. I mean, this is it's a complex issue, because it's physical, emotional, psychological, everything is wrapped into this. But any final words, I guess, in terms of rebuilding that healthy body image that you can provide for us?
Yeah, that's a difficult question. I never give up hope that people can resolve these issues. I truly believe that people will resolve the issues. I'm just there to kind of help them on their way. This work, I've been doing it for more than 20 years, has taught me so much about being a human being. I am humbled each and every day that people put their trust in me and are open in a way that sometimes surprises me. I'm grateful to you, Kathleen, for giving me this opportunity, and to Ali, who's been working in the back. I'm grateful for this opportunity to have to speak to so many people who may be awkward and shy about coming to see me. And I hope, the audience has seen that I'm a human being. I kind of joke around a little bit, because with these serious topics, sometimes you have to. But if a joke falls flat, I'll never make a joke again. And I'm ready, willing, and able to see any and all of you. So, do not hesitate to contact me.
Dr. Katz, thank you so much. I think your enthusiasm for this subject is really contagious, and we're just really lucky that we do have you here at Cancer Care. It's I think we should all just appreciate how much you've done for this topic and the books that you've written. It's such a wealth of knowledge. I really appreciate you joining us today.
Hey, talk is cheap, send money. No, I'm kidding.
and thank you to our audience for joining us again. I wish you all well, and take care. We'll see you again. Thanks again.